Okay, doctor, it's all yours. We're recording.
Okay. Well, good evening, everyone, from chilly Orange County, California, where we're apparently in our purple phase of the virus issue. We've been getting worse than better, but I think eventually we're going to get over this. The thought occurred to me when I was asked to give a presentation that the most common thing that I've been asked about is people that have had primary treatment, but now all of a sudden their PSA is rising. So this is the largest group of new patients that are in the prostate cancer group. We always thought that recurrence rates after prostate cancer surgery or radiation to the prostate were very low, but as it turns out, the reality is that 12 to 15% of the fellows that have had primary treatment then have a rising PSA at some point. And as I was researching some 200 articles for this evening's chat, it became more obvious how complicated this whole thing is. There have been so many advances in the last year, even since the last time I gave a talk, and we're going to cover some of those advances too. I also want full disclosure that only half of the people signed up are from my family. And as long as everybody understands that. And I'd also like to tell you that today is my anniversary.
Happy anniversary.
Married 43 years. I asked my wife what she wanted for her anniversary present, and she said a divorce.
Oh, no.
I said, well, I wasn't planning on spending that much money, so I bought her a watch. And time will tell, I suppose. So let's get started. Here we go. So this, we just mentioned, this is the largest group. Most of the men that have a rising PSA after primary care do not have any symptoms. You don't wake up one morning and say, oh, my PSA is 0.2, it was 0.1 yesterday. So it's basically a group of people that are very asymptomatic. And the only reason you can tell that their PSA is going up is by having one drawn every 4 to 6 months, which is the usual follow-up for this group of people. Workup, it's pretty much the same as the traditional workup when you first get started. What is different now is that we're getting approval and more information about the 2 new scans that are available, especially the prostate-specific membrane antigen scan, PT scan, CT scan, that is really revolutionizing how we look at these metastatic workups. In the past, bone scans, CAT scans, MRIs, they didn't really help that much with where the prostate recurrence was. And these newer tests are also finding where the metastasis is, and incidentally finding incidental cancers in other organs. So this is an area that I know there was a talk a couple months ago, but this is something that is really changing the entire nature of the workup. And the thing that I mentioned in my last talk is even more important now is adding the genetic component to any workup for prostate cancer. It is just so critical that the oncologists know what the genetic abnormalities are, if any, so that appropriate therapy and the era of precision treatment is upon us. Last time we gave a talk, we were talking about new findings, new drugs. Well, the list is just tripled, and each one has a different indication for a different genetic component. Sadly, only about 10% of the fellows are getting genetic evaluation. This has to change because the treatment will be specific according to what genetic abnormalities are present. The elevated PSA always get another one because the lab, they just don't do as many PSAs as they used to. And sometimes you just get different numbers. Either repeat it in the same lab or repeat it in a different lab. But you have to be careful that you don't take one random blood test and make too much of it. Repeat it and make sure it really is elevated. And the same thing is true of original workups for PSA elevations. No recent sex, no recent exam, and no recent infections. And that's not just for the doctor, that's for the patient. So you got to make sure that you're on an even playing field here. We used to do an ultra-sensitive PSA for very, very low levels. That's not quite as important as it used to be. What's more important is what the PSA is doing from one point to another. So you get one, if it's slightly elevated, you get another one in a month or two and see that which direction it's really going. We used to do a lot of free PSAs that aren't bound to protein. It's called, if the number is high, it's a good thing. This is part of one of the combination management tools, which we'll talk about later. Free PSA really never caught on very well, but it is still a very important test. And the prostate health index, which includes several of the PSA molecules, including the free PSA, the bound PSA, and several other proteins that indicate prostate issues. The prostate health index is another good way to look at whether something is significant or not. And certainly the MRI is taken front and center stage for almost everything that gets done with the prostate these days. Multiparametric MRI has really changed the entire nature of biopsies, the entire nature of workups. And I think it's probably one of the best advances. Health plans don't like to do MRIs simply because of their cost, but MRIs can really change what we do with prostate cancer. And the 4K is a new test that they take 3 forms of PSA plus the other protein, and it's supposed to have a very high specificity and accuracy. Not being used very much, but it is certainly out there and available. And believe it or not, there's a urine test now that you can take that looks at the messenger RNA. Of course, messenger RNA is in the news because of the COVID vaccines, but messenger RNA from prostate cancer gets excreted in the kidney and surrounded by a protein. So it's in a little vesicle and they can actually test for it. It's strange to think that we have cancer RNA running around in our urinary tract, but it is very high specificity, obviously very expensive and hasn't been well accepted yet, but it is an exciting test. We've talked in the past about the first generation anti-androgens. Unfortunately, they only work for a certain period of time. Lupron, Zoladex, and Trelstar are the 3 that were the most common. I think everybody has heard the word Lupron before. Lupron was one of the first that to suppress the pituitary's production of male precursors, and it blocked most of the androgen production, but not all. Second generation anti-androgens mentioned my last talk. All of a sudden, these things have proliferated. It's incredible. There are now 4 second generation anti-androgens, each one a little better than the one before. And the last one on the list, darolutamide, which should be approved this December, is got the fewest side effects. As I mentioned once before, its side effect profile looks exactly like the placebo profile, which is an amazing thing for a new drug. So we'll talk about that a little bit. Abiraterone has been around since 2012. It inhibits all androgen biosynthesis. Unfortunately, it has side effects. You need to take prednisone to make up for other hormone deficiencies. It is mildly effective. It's certainly more effective when used with other treatments. It's probably been around as long as anything, and it hasn't dominated the space, but it's a very good medication. The problem with the second generation blockers is that there's a risk of seizures. They do cross the blood-brain barrier, and unfortunately, that is something that is seen in 4 to 6% of the people that take them. Darolutamide does not go across the blood-brain barrier, so it is the favored second generation anti-androgen. It's called Nubicek or something like that, and I'm not sure how they figure out these names, but they're very much tongue twisters. So I think darolutamide is going to be the most successful of the second generation anti-androgens. So what do you do if you have an elevated PSA? Well, the same term, active surveillance, applies to that. You can wait and get another PSA and see what the doubling time is. If the doubling time is below 6 to 8 months, it probably is something you can watch. If the doubling time is more than that, then you really need to then move on to treatment. If you've had a radical prostatectomy, the treatment after a rising PSA that has been confirmed and worked up completely is radiation. The stereotactic body radiation therapy that is very popular right now, the short course, high dose, fewer side effects, and very, very effective in treating a rising PSA after radiation. Does not require any anti-androgen or chemotherapy or any other treatment. And about 80% of the fellows that have a rising PSA after radical prostatectomy, the PSA goes back down to non-detectable, and they do quite well. If you've had radiation treatment and have a rising PSA, surgery is almost never done. It is very difficult to do because of the scarring that radiation causes. So if you've had radiation treatment and your PSA is rising, it's a good idea to start on the androgen receptor inhibitors and combination therapy, which we'll talk about in a little while. There have been several advances in HIFU. Again, a couple of months ago, there was a talk about HIFU. I'm not here to sell anything, but HIFU has found its home in segmental treatment, where you're only going to treat a certain area of the prostate that the MRI shows to be recurrent. Cryotherapy is pretty much given up. It's still being used in some centers, but it's not terribly effective. Laser therapy is an amazing, all of a sudden, we've had lasers for years, but all of a sudden the MRI can show you where the recurrence is, and you can take a laser beam and put it through the transducer, and you can actually destroy the part that the MRI says is the recurrence. I think segmental laser treatment is going to find its day, and as it gets more popular, I think it's going to really evolve as a good treatment. The first generation anti-androgens, Lupron, what a mess Lupron created, because the doctors used it because they got paid a lot for it, and because we didn't have any guidelines. So people were on it for years and years. And the anti-androgens of the first generation almost always quit working. So they had a limited efficacy. Second generations, especially the darolutamide, are going to be the answer to recurrence. Darolutamide is being tested with all kinds of other combinations, which each one seems to be a little better. Right now, the hot study is darolutamide plus androgen plus the plus the immune therapy, and especially Propen is all of a sudden back in the
Plug it in.
market for use in this. I'm getting.
Could I
some
ask
feedback.
everyone except the doctor to mute their system? Would everyone mute except the doctor? There's some real bad background noise.
Yeah,
Everyone, please mute.
Immunotherapy has been around for quite a while. It was approved in 2010.
You understood that? Hey, can you mute Paul, please?
I can't, Neil. That's why I'm making an appeal for everyone to mute themselves. I'll work on that for next week, but I know that ability is in there somewhere, but would everyone mute their sound? There's someone with really bad background noise or
Gone now. It's just, as I was talking, immunotherapy has been around for quite a while. It's never really caught on. It is now showing signs of being helpful as a second addition to darolutamide and a second addition to the abiraterone. And their results are starting to look very good for the combination therapy. And then, of course, we have all this genetic information coming down the line. The new PARP inhibitors, which is a whole new group of treatments that are specific for men that have genetic abnormalities in their prostate cancer. And we've always known that certain cancers just don't seem to respond to the regular therapy. And now we're finding out that most of those cancers have all kinds of genetic abnormalities. The most common were the BRCA1 and 2, the ones that are common in breast cancer. Men that have those have not responded well to traditional therapy. And there's a list of 10 or 12 other genetic abnormalities. Each one now seems to be being paired with a new type of therapy, and that group is really doing well. I think the first of those will be the PARP inhibitors. It's just a class of medications. But this is the exciting part of what we've got going on, this specific treatment for specific genetic abnormalities. And lo and behold, we've always known that African-American men seem to have a worse time of it with prostate cancer. And what they were discovering is they're almost always it's due to the different genetic abnormalities that are not necessarily present in all prostate cancer. And so the selective therapy with these different inhibitors is going to be the exciting avenue for treatment in the future. The genetic information is just so critical that if you're not doing well, that genetic information can make all the difference in the world. And then chemotherapy, we all always thought chemotherapy was not much of a resort for, or last resort for prostate cancer, but the new docetaxel chemotherapy, cabazitaxel, is much less toxic, much more effective, and now showing in combination with some of these other drugs, it is amazing the response, especially in men that have a lot of disease. What they're finding is that you use different combinations of all these things, and it is amazing what is building in the research world. There are 83 different studies right now with different combinations just in prostate cancer. And if you can think of a combination, they'll put it together and get a study out of it. It's really exciting. The Provenge immunotherapy is now being added as a second treatment for some of these others. Again, with darolutamide, it is really showing some promise now as not a primary treatment, but as a secondary treatment. Combination therapy, sadly, if you're resistant to one, a lot of times the going to another will not help unless you have the genetic information that you're missing some of these different genes. And I've always found it fascinating that almost all of these genetic abnormalities are found on the X chromosome. And of course, men have an X and a Y, and women have two X's. And so, although we can't blame our wives and girlfriends, etc., for our prostate cancer, it is interesting that most of the abnormalities are coming on that X chromosome. So you probably do get this genetic part from your mother. Chemotherapy, we mentioned, is now being used in the different lab tests that are available. We'll just skip some of this and go down to the multiparametric MRI. What is happening in the MRI space is that they've added new tracers to the MRIs, and now they're getting a very, very good look at where the cancer is. There are some studies that are showing that if you get an elevated PSA, that you should go straight to a multiparametric MRI, which can tell you if you need a biopsy and where to biopsy. And this is exciting because we've never had anything like that before. It's been like pulling teeth to get health plans to cover MRIs, but they are really turning out to target the biopsies. And when you target biopsies, because the MRI says it's abnormal, the success rate for finding significant prostate cancer is really high. And the chance of finding insignificant prostate cancer, Gleason score 6 and below, is that almost never happens. One of the things that is happening with the PET world, this fluciclovine, it was I think discovered at Emory University, which is my alma mater. And what they're doing is they're using it to scan before you do radiation, and they can actually show you, or the radiation docs, where to concentrate the radiation. So if you use this new stereotactic body radiation treatment, where it's high dose, few treatments, and just hit the spots that are abnormal, you've got targeted therapy, and it's just so much more useful and helpful in getting rid of metastasis. They're even developing a machine that you take into surgery, where you give this tracer, and then it shows you where the margins of the cancer are, so that you can make sure that during surgery you get good margins. You wonder where does the cancer come from if we take out the prostate or radiate it? And the answer is the cells must be outside the prostate to begin with, and it's hopeful that these new PET scan evaluations will show us exactly where that cancer is. And there's a study that's ongoing that had to be stopped because it wasn't fair to the other group that didn't get the treatment. If you have a rising PSA, use this PET scan and then target the radiation. The success rate was so high compared to the placebo group that they actually had to interrupt the study. And I think there's going to be a lot of noise in the urology world for use of these scans. And just get back to this PSA screening thing, since I've been retired, they've decided not to do PSAs on people. Or if they're going to do them, they have to do them with good informed consent. But what's happened is that the number of metastatic cancer diagnosis has doubled in the last 4 or 5 years. And so this is kind of backfired on them. And there's going to have to be some reasonable way that we do PSA screening. One of the suggested things is if you're 55 or older, that you consider having a PSA, and if it's normal, not having it again for 5 years. Some people think that should be age 40, because every once in a while younger men have prostate cancer, but that's open for debate. Certainly most African American men that are 55 need PSAs. They probably need to be screened long before age 55, but the current new recommendation will be age 55. If you have a family history of prostate cancer, absolutely need to at least know what your PSA is doing. Don't need to do it every other month, but it needs to be done. It needs to be done frequently. And then again, prostate cancer tends to be in men over 70. So it's not unreasonable to have men over 70 have a PSA, and depending on what the number is, not have another one again for a year or two, maybe 5 years, just like screening for colon cancer has changed. This is going to have to change back to more screening. We just can't let all these men arrive in the office with metastatic disease. Obviously, all this comes with informed consent. You can't get people to wear a mask during the COVID thing, and you're not going to get some men to do PSAs or exams. But if you give an informed consent and say, this is what you're missing, or this is what you might miss, then I think it's a good thing. It was shocking to me when the American Urologic Society came out with a pronouncement that we shouldn't do digital rectal exams anymore. And I think in 41 years, I probably did over 100,000 exams. I thought I got to apologize to all those guys. Some of them still send Christmas cards, by the way, but that's another story. All of these things about not doing exams, it just seems crazy to me. We picked up 1 or 2 patients a year that had normal PSAs but abnormal exams, and by golly, they had prostate cancer. Now, the argument can be said, well, maybe it was insignificant cancer, but insignificant is a funny word. You put these people on active surveillance, and that's not insignificant. That's biopsies, that's PSAs, that's MRIs. It is hardly insignificant. So I think there's, for some reason, been a swing away from it. It's probably going to come back. On the other hand, it'll save a lot on KY gel and gloves, but I'm not sure that was the intent. When we talk about androgen suppression, that we used to say neoadjuvant therapy before and during radiation treatment. Huge Italian study that said this was the best way to go. It sensitized the cells. It made it better. And then they said, well, adjuvant therapy is better. During and after treatment, don't have to give it before. And the gold standard was that we gave it before, and the gold standard now is that we give it during and after, especially after. And the information is now coming to light that men that have radiation do better if they have their androgen suppression after their treatment is completed. And that's certainly going to change one of the huge things that we used to do. Neoadjuvant is gone, adjuvant is back. So all the things that were old are new again. But this is why we can't get things straight with COVID. You see one study one day and another study another day, and one expert this and one expert that. Thank God, at least there's now some standardization of treatment of prostate cancer. And this is a game changer for radiation patients because it just means that if they can get a better result with having the androgen suppression afterwards, that's very good. I'm not sure what we're going to do with this couple thousand Italian patients who did the original study and did better, but that for some reason that just hasn't been the experience in the rest of the world. Genetic testing, can't say enough about. Not enough people are doing it. The advanced prostate patients have to know their genetic profile so that these precision treatments can be made. That is just critical. Otherwise, you're just trying a bunch of things. And certain new drugs that are coming out, the PARP inhibitors, certainly the CART inhibitors, all of the different immunotherapies that are available have to do with genetics, and they have to do with the BRCA genes, the genes that repair DNA and the prostate cancer. If you can inactivate those genes, then the prostate cancer DNA cannot be repaired, and that prostate cancer cell will die. And the results are rather impressive in this group of people. So these precision medicine is here, but you have to have the testing to do it. And the other thing that is really exciting, if you can use that term in the urology world, is Relugolix. Goodbye Lupron, goodbye Zoladex. Regulolex is here. It's an oral drug. It's going to be approved on the 20th of December. It does everything Lupron does, but does it better, faster, with fewer side effects. Now, it's going to revolutionize the office practice because Lupron and Zoladex were given as injections in the office and charged on one part of Medicare. Now, all of a sudden, we're going to have an oral drug that's going to go to everyone's medication coverage. And it's going to be interesting to see how that works. But the biggest advance with it is it almost eliminates the cardiovascular problems that Lupron and Zoladex. Lupron and Zoladex had about a 15 to 20% chance of giving you a heart attack or giving you a stroke or giving you a clotting problem. And Regulolex almost eliminates all this. So it's an oral version of Lupron, and it is here. And Regeneron or something like that, a company is just going to do really well with that. Officially, it's a GRH antagonist, which is exactly what Lupron is. It's an oral medication. It reduces major cardiac events, and it reduces testosterone quicker. When you stop it, the return to normal comes back within weeks, which with Lupron and Zoladex, you may never get it back. And it has much less in the way of side effects. You don't get the osteoporosis that you get with Lupron. You don't get the GI problems that you get with it. And we're going to go back to studying intermittent therapy, which we used to do a lot, because you can get the return of testosterone quickly, feel better for a while, and then go back on it with no reduction in efficacy. So the PARP, the PARP error, you'll hear about this on television, on the radio. These are targeted therapies for genetic abnormalities in the DNA repair genes. The protein that helps repair the DNA is blocked, so the DNA can't be repaired. The prostate cancer cell dies, and that's the end of that. 30% or more of men have this genetic alteration, and isn't it interesting that that's about the percentage of men that don't do well on other therapies? And so they've identified 10 to 12 genes now beside BRCA that are involved with this, and each one now has a different therapy assigned to treat it. And so this targeted therapy idea, it is really taking off, and I think it's the exciting part of this whole thing. BRCA1, BRCA2, as I mentioned, breast cancer. I don't know why they use so many different acronyms. I think I would have called aggressive prostate cancer WWF or something like that, so that at least there's something. BRCA1, BRCA2 with breast cancer, you could have called that left and right and just been as far ahead, and it would have made a lot more sense. But anyways, in the PARP era, this with these BRCA deficiencies, the survival is twice as long in the group that's getting this new therapy with acceptable side effects. And this is in a group that didn't do well. In fact, they just didn't have any hope of doing well. And the BRCA2, that little a is supposed to be a 2, seemed to be the group that did the best with this particular therapy. But there's a list of 8 to 10 new drugs, immunotherapies, and they're going to each match up with a different DNA genetic issue. And this targeted therapy is going to take that group of men that we didn't do well with before and give them a fighting chance. Side effects have been pretty acceptable: anemia, low white count, nausea and vomiting, and the desire to go shopping, the Lupron and some of the other drugs that took away male hormone are gone with these targeted therapies. So we won't see a bunch of men out shopping now that are on hormone therapy. There's another one called an ATR inhibitor, which stops DNA repair. And it is even more exciting than PARP in that it is new and maybe has fewer side effects, but it is just in its infancy. So we'll see where it actually goes. Insurance coverage, not so good. You have to have an advocate. Medical directors do listen to facts. That's their job. They, believe it or not, do. But if you just send in a request, they'll just send it back. If you have a doctor or an advocate that will talk to them directly, explain the facts, almost all of them will eventually approve some of these treatments. And then I didn't get to make a slide of it, but just today I got an email announcing that there is a new ultrasound of the prostate machine that is 300% more effective than the ones that we used. It is more effective than the MRI in picking up prostate cancer. And all of these mother may I beg for MRIs may not be necessary in the near future, because these in-office ultrasounds are going to be just as effective, and you won't have to add the MRI to the ultrasound program, which is really expensive. And you can do the ultrasound, do the biopsy if you need to. It'll be a targeted biopsy. It is really exciting to see all this stuff happening. This happened so late this afternoon, I didn't get to make a slide of it, but that and Regulolex and some of the targeted therapies are the three really exciting things that are happening. I think the switch to stereotactic body radiation has been a big boost. Fewer treatments, larger doses, targeted to the area that the PSMA tells you to go to. These are all very, very exciting things that are happening. And the future looks good for continuing to figure out what drugs mix with what other ones, which combination therapies to use, and how to use them. Get the genetics, and then go get the appropriate therapy. So that's the end of my prepared remarks. My family can now go back to their dinner.
Doctor, could you stop your sharing so we can?
Could I stop my sharing? You sound like my divorce lawyer. There we go.
Thank you.
I have to give my daughter a lot of credit. Lauren Metzger Warner, she's a whiz at this stuff. I wouldn't have been able to figure this all out myself.
Thank you, Lauren.
I appreciate it. And I see a name down there of my Westlake friends. It looks like they're on board. So hello, Westlake.
Well, I think we're going to open this up for questions. You can submit your questions through chat, or you can simply ask the doctor the questions. Do we have anybody want to go first? I see Kelly. Kelly, go ahead. Kelly, you're going to have to unmute yourself. There you go.
Donald should go first. I'm a new person, so Donald can go first.
Okay, Donald.
Hi, I'm Don. My name is Don Pikovich. I had radical prostatectomy in 2005. I've been through the whole routine: Provenge, Lupron, the PARP inhibitor, and I'm now in remission for 12. Let's see, it'll be 15 months in January that I haven't had a measurable PSA reading at City of Hope. So whatever you said worked. My question, if there is such a thing, and you answer it, is I would love to be able to get a listing or a report from my doctor up there explaining everything that I went through, so that when I hear a speaker like you, I can put more efficacy into what you're saying as to how it relates to me. And I don't have that. So I hear about PARP inhibitors. I was on a PARP inhibitor for a while, then they took me off. And there's never an explanation given. Is that standard, or is that something that I should be insisting on getting an answer for at City of Hope?
Well, I think, can you hear me?
Yes.
Yeah, I think that, everyone practices differently, but that is just poor communication. You absolutely should have that information. You should have it in front of you, and you should discuss it with them and know why they did what they did and what they want to do, and how they want to follow it, and all of that. That's just poor communication. They're doing the right thing, but they're not good communicators. You have to either have an advocate for yourself or be your own advocate, but you shouldn't walk out of there without printed information. And then,
Okay.
boy, it's really easy to look up on WebMD or any of these sites that show you the research. I mean, there's 8 or 10 of them, and it gets complicated to read some of that stuff, but it's all out there and available. As I said, I looked at over 200 articles to get ready for this. And, you'd read 3 one way, and then you'd have a 4th one that said something else. So you had to look at how the studies were done and put it all in perspective. But I wouldn't leave that room until that person communicated with me. You block the door, they'll start talking. You put the glove on.
Now I need to get 15 years worth of reports, I guess. I would just like to see some kind of a progression as to what they did to me and when they did it. They took a sample of my spine 10 years ago, and that was my, what is it? The test, anyways, to determine my genetic makeup. It was a genetic test. And that's what it was for, but they never told me. They were just saying, they just told me I was getting a sample of my spine for a genetic test, but they didn't say why.
The other trick is you put the glove on in the room and they'll pay attention and tell you.
Thank you. By the way, thank you for your speech. It was very, very informative. Thank you.
Kelly, I believe you were next.
Thank you, doctor. I'm here with my dad. Randy is the new man on the screen. I'm a physician, and I think I pride myself in trying to read these articles and make sense of things, but I've just been shocked at how much, like you said, how much info there is out there. And my dad was a Gleason 9. He had a radical prostatectomy last year, and has been doing very well, but will likely be having to get radiation. And we just met with an oncologist who said he's actually not going to need the adjuvant anti-androgen at this time. And so I guess my question is, like the previous question was just asked, like a progression, it would be so nice. Does it also vary between Gleason scores? Like, it just seems like there's so many different permutations of treatment options because there's so many different grades of cancer. Like, was what you presented the general progression for like lower grade cancers, or does it apply to pretty much everything, I guess is my question.
Most of what we're talking about are the high grade cancers.
High grade.
High risk. The Gleason 9 needs to be watched like really closely. We used to say, yes, you had to do adjuvant radiation treatment in Gleason 9 after radical prostatectomy. And now they're saying, no, watch it and don't do it. You'll get a better effect if you wait. Mm-hmm. You'd think the earlier you use some of these other things, the better off you'd be. But the fact is that the studies don't show that. Mm-hmm. They show you use them when you need them. Now, if he had a Gleason 9, they surely know the genetic component and know whether he's going to be going down this road or that road. And with that, you just have to say Gleason 9 is a highly, it's a serious situation, and you want to watch it closely. But it isn't the end of the world like it used to be. The stuff that's coming along is just amazing. And if they get it early, if you get a PSA up to 1.2 and you radiate that person with some of the newer radiation techniques, whether it's proton or, there's all kinds of argument which is the best. Those fellas then do very well for a while, then you add something else and you drag it out until they have a heart attack and nature gets them anyway. And that's the optimum. But the targeted therapy in a Gleason 9 is absolutely the only way. You can waste a lot of time trying a lot of other stuff. But if you know that genetics and, there's 3 major genetic companies right now, but there's several more that are advertising they're all over the place. The only one that I know that is really reliable is Genomic Health out of San Francisco. The GPS score, they're the biggest. They've been around the longest. They just got bought by the guys that make the home kit for colon cancer. So I guess that's the two are together now, but they changed their name. But Genomic Health is easily the leader of the band in that field.
Thank you.
Mhm.
I have a question now from Lauren. I had a low PSA below 2.0, but prostate cancer was discovered through a DRE. I had radiation and am now coming off Lupron. Since my PSA was low to begin with, how is this monitored going forward?
Well, the only thing missing there is a Gleason score. Any idea what that was?
Lauren,
My Gleason score was 8s and 9s.
Gleason 8 to 9?
8s and 9s, yeah.
Well, and how long ago was the surgery?
I didn't have surgery. I had radiation in May of last year.
So,
And-
yeah.
Yeah, and I'm coming off of 2 years on Lupron.
Yeah, and that's the Italian way. The group in Italy, for some reason they had 1,500 men that I know Italians wear nice suits and they're all artsy and stuff, but now I know why. They're all on Lupron. None of them have any male hormone. It's amazing. That you're in a good spot because I don't think those Italian studies were wrong. I think it's just a different group of people, different genetics. But if they know the genetics of your Gleason and you're doing well with treatment and you've gone through the Lupron, in the future you won't use Lupron, you'll use this new oral one. And then depending on what your genetics are, if your PSA goes up, then you've got all of these avenues open to you. And we have fellas really doing very, very well. You have to remember when you do these studies and you like this darolutamide study, men went from 14 months of disease progression to 43 months. In medicine, that's unheard of. If you went to 12 months to 18 months, it was the end of the world. They thought that was a great response. These responses are really durable, and those are median responses. Median means half of them are above that, half of them are below that. So that in any individual case, depending on the genetics, you should be able to ride this horse for a long ways.
okay, Raul wants to know, thank you everyone for a great presentation. A digital exam by doctor observed some nodules, just a month old, from a biopsy that yielded a 3+4 Gleason score. I have a PSA of 1.0. I'm just trying to get educated. A surgery has been recommended. Still trying to educate myself on all the options. Again, just wanted to say thank you. Doctor, you want to comment here on a 3+4, but a PSA of 1.0? That's interesting.
Well, that's not the usual way for a 3+4. Gleason scores, the first score is the most predominant type of histology in the prostate cancer. The second score is the secondary type of cells they see. A Gleason 4+3 is generally considered high risk enough to consider therapy. A Gleason 3+4, the major part of the prostate cancer is still a 3, and the minor part is a 4. Active surveillance is certainly an option. Active surveillance is a lot of blood tests. It is a couple biopsies, it's MRIs, but it's careful watching. 1.0 is very, very low for that. I would think that with that information, radical prostatectomy certainly should be curative, as is radiation in that. But I think The Canadian study where they started active surveillance watched these fellas, and a lot of them did very, very well for a long, long time. And you got to remember, most of us are in an age where, you know, other things happen, and prostate cancer in most people is still a slow growing issue. It is rare that without genetic abnormalities that it is a rapidly progressing thing. It does happen. I'd be inclined to put that person on active surveillance, really active surveillance, watching it very, very closely, doing all of the things, you know, the vitamins and the minerals and all of the diet and exercise, all the things that are non-medical. Doesn't hurt to do them. Just an aside, when I got involved with this Fullerton group, it was because somebody, I don't remember his name, but he's an engineer, came in the office and said, well, we got this vitamin that's curing prostate cancer. And everybody wanted it. And so I researched it, and it turned out the data that in the preliminary studies looked really good. And of course, they got around to studying it. And the reason that the vitamin was good, because it was laced with Ativan. So everybody was, all the leaves are brown, and female hormone, which of course is a treatment for prostate cancer. So of course it was going to work in some people. So I don't know how long, that was in the early 90s, I think, mid 90s. That lady's lab in Brea, I think she ended up going to jail.
Brea?
Well, I think so,
She
where
was
her
in Brea.
PSA went up for some reason. I don't know why. Does that answer that one?
Thank you very much. Appreciate that. Yeah, my biopsy was just done 3 weeks ago. And the 1.0 has been 1.0 for the last 4 years. My dad had prostate cancer. That's why I always get a PSA test. It's a little overwhelming, all the information.
It is overwhelming.
Yeah.
Could I ask a question, Raul?
Sure could.
Yes, sir.
What was the involvement of the 3+4? I mean, how much cancer was there?
Well, interestingly enough, I joined a forum, and somebody from the forum asked me that question. I felt kind of foolish. You know, as an engineer, I always do my thorough homework on everything, and I went kind of naively to to the biopsy, and then I got a call about the 3+4, and then I didn't know the questions to ask. Now I'm getting more educated. I wish I would have all the information I gathered the last week. I wish I would have had when I had that call with the
Well,
urologist.
if
So
you could
no,
get
I
a
don't know.
genomic score on that, you could easily go on active surveillance and watch it.
Well-
In that case, without the genetics, you're really, you know, it's really hard to know what the real thing to do. But the GPS score is really would give you the assurance that you could either do active surveillance or need primary treatment. But the genetics in that would be fascinating, because that is an area that's getting close to go either way. And so that, you know, I would go back and tell them, you know, I demand to have the genetic test done. They can do it on preserved tissue.
I'm on active surveillance, and they tell me that active surveillance is appropriate for someone with a small amount of 4, you know, but if he has a lot of 3+4, it's not appropriate.
Well, the 3 is
Plus, let me say one other thing. Raul, did you have a trust biopsy, a random biopsy?
I wish I
Instead of
could
a
answer.
targeted one?
I don't know.
Right.
Okay.
Well, the predominant histology there is 3. And the 4 is the minor. So the higher grade is the minor part, and that would be of absolute interest to see what the genetics are. The GPS score would tell you whether you're a good candidate for AS or whether you should go on to treat.
Is that a request that the patient has to make to get a generic test? Or, I mean,
That was breaking up. I actually didn't hear that.
So this genetic test, the patient has to request that? How does that come about?
Well, in the best of worlds, the urologist would do it. When the patient requests it, if it's approved by the insurance, then it is a very simple matter. The company requests the specimen and they get it, and then they study it. It's really up to the person that's taking care. And in most urologists, as I say, aren't bothering with it, but it is the key to the precision treatment that is really evolving and evolving very rapidly. It's a shame that more of the guys aren't doing it, but certainly all the university centers are doing it. And it probably is a good idea to consider second opinions with university centers. It's so difficult to keep up with all this. And I think they have urologists that are just doing the oncology part. And so that's every day they deal with this. I don't know that the guy in private practice can keep up with it anymore. But I would call the guy and tell him you want the genetic test and don't take no.
Okay.
You could also check and see if you have a MRI guided biopsy with a Tesla 3 machine. And additionally, I sent my results to Johns Hopkins to get my biopsy double checked, and it did come back the same as what they had tested. But sometimes these biopsies are subjective to different opinions. So you've got to have it verified and check that out.
Yeah, I am getting the report via email, which I was planning to send to Johns Hopkins. Somebody advised me on that. I am getting an MRI, a prostate MRI on Saturday. Why? The fact I don't know.
Hey, Raul,
Sure.
they don't want the pathology. They want to see the actual pathology. So you basically need to call your doctor's office and ask them to send the pathology. It's not the written report.
Oh, okay.
They want the actual tissue.
And also, I like to say something to Raul, and there was another, please forgive me, the other man who needed information about his condition. This is something that you paid for, and you have a right to get all the information. So if somebody asks you, like if this doctor asks you a question, you want to have all the information in front of you. So you need to have that from your physician.
Okay.
And they have to give it to you. It's the law.
May I ask one last question? So I am getting an MRI on Saturday. Is that usually what they do? Biopsy first and then an MRI? Shouldn't it be the other way around?
Well, I was a little confused by that. The MRI is often done before the biopsy to see what it looks like. And if it doesn't show any areas that are suspicious for high-grade cancer, you can do active surveillance just based on the MRI and skip the biopsy. If they see areas that are suspicious, then they need to do targeted biopsies. And so they fuse the MRI images with the ultrasound, and the ultrasound in the office then can show the doctor where to take those targeted biopsies. So that's the MRI fused with the ultrasound. With this new micro ultrasound, you can skip the whole MRI part and go straight to the high resolution 30 megahertz ultrasound and get the same information. So there's a radical change in getting control of how this is done. It'll be much quicker, and you won't have to worry and have so many moving parts. Radiologists never were enamored with doing prostate things anyways. It just didn't seem to fit into their idea of how to do a radiation or how to take x-rays. So getting that back in the hands of the person doing the biopsy is really going to be a big deal.
Thank you.
Do we have any other questions tonight?
I have a question.
Go ahead, Larry.
Okay, I'll ask my question first and then I'll give a little background. My question is, why didn't Firmagon ADT work for me when I finally took it? It absolutely did not work. The disease progressed. Prior to that, I took 3 cycles of lutetium in Australia. Absolutely did not work. The disease progressed. And I was essentially treatment naive. In 2009, I had surgery, Gleason 4+3 with 5% Gleason 5. Margins clear, 58 lymph nodes all clear. I had a recurrence at the anastomosis, radiation to that, into the prostate bed, then nothing. And my PSA would be straight line. And in about 2008, 2009, it reached 19, but I wasn't concerned about it because I had no symptoms and it would go up 1.6 nanograms every 6 weeks. No big deal, straight line. And then it just took off. And within 6 months, it was at 94 in spite of the lutetium. And then when I took the Lupron, it went down to like 34, 35, but then I did another gallium scan and or PSMA scan, gallium PSMA scan, and it shows more bone metastases and a progression of the disease. So I have, I'm on Zytiga and they still have kept me on Firmagon, changed to Lupron because I couldn't stand the side effects of the Firmagon. It wouldn't do anything for me anyway. So I have 33 lesions that I'm following with imaging. Soft tissue seems to have caused the lesions to slow down, but the bone lesions just keep popping up. I've had 17 of them treated now, whack-a-mole with proton therapy. So back to my question again, any ideas on why I'm such a failure on treatments? So like the ADT thing was supposed to work for 2.5 years. The Zytiga was supposed to work for a person who's treatment naive like me, but I'm stage 4 metastatic. And this treatment I'm on now, I'm a little iffy about it, but the doctors don't feel that I've exhausted its full potential yet. My PSA now is 1.19, and it goes down 0.2 every 6 weeks or so.
I know there's a question there. I'm just not sure what it is.
Oh, the question is, what's different about my cancer that it's failing these treatments that work for everybody else? Like ADT, doesn't work.
What is your genetics? Do they do genetic?
I have 1 mutation. There's no medicines for it.
What mutation was it? Do you know?
Oh, you know, there's 2 of them combined together, and that's it. So.
Well, what they're going to eventually find is that there is a mutation for that. Lupron works for a while, then it doesn't work on everyone. With a low PSA right now, unless there's a targeted therapy on a clinical trial, which again, out of the 83, there's going to be 1 with your mutation, that would be probably the best way to address that. It certainly would be interesting to use the immunotherapy in that setting. Provenge was never caught on much as a primary therapy, but when you add it into a complex situation like yours, it had almost a 50% response with low PSA at 3 years. So that certainly is a possibility. But I think someone needs to take that mutation, maybe rerun it with the newer genes that they're finding. How long ago was that done? And which company did it?
A couple years.
Which company did it? Do you know?
I think I had a foundation one, and then I had another one.
Yeah.
I've asked the doc.
I would have them send the tissue to Oncocyte and get a GPS score. It is clearly the best of all of them. they're doing it different than they did a couple of years ago. And they're finding more mutations. And then, as I say, there's 3 or 4 new drugs. For every mutation they find, they're finding a drug that seems to match up to it. So I think that's an avenue I would certainly search. Polaris and the other one are not nearly as sensitive as the GPS score. And the newer way to do them, I think, is more accurate than the older way. But I think that's probably the direction that you should head.
Well, there are 2 new genetic or genomic tests, liquid biopsies that have been approved this year. One of them tests about, I don't know, 30 or 40, and the other one tests a lot more than that. And it's the Foundation 1, and there's some letters after it. So it's a newer test. And that's the one that they want me to take because of the number of genomic mutations that they're looking for. So I'll be taking that within the next month. So we'll see what comes out of that. I don't expect anything to come out of it. I'm not as optimistic as you are.
Well,
But,
Foundation 1
I'll try it.
it hasn't been validated like the GPS score. I think if I were in that situation, I'd, do the liquid biopsy. It's new. Who knows where it's going? But I would certainly get that original tissue and find out if one of these 23 genes that they're looking for now has a matchup as far as treatment. And maybe they didn't get the right mutation. Maybe the technique didn't allow it to be discovered, or maybe they've got something new. But that certainly is a situation where there's got to be a genetic mutation going on somewhere.
Well, I had 2 or 3 different genetic tests, and they didn't show anything. This genomic health GPS, is that how you would ask the doctor? Is that the
Yes.
full name of it?
It's out of San Francisco. It's look on WebMD. There's a great video where the guys, some expert looked at all 3 companies and broke it down, and clearly they were the top of all of it. And even now they're doing them different than they did. So if you had one of the older tests, it may be that they have found new things since then. Since this COVID thing came along, and all of a sudden the Chinese knew the genetic code for this thing, it has really changed a lot of the research. A lot of the stuff that they were going to have to go through to discover has already been presented to them. And the trickle down effect of that is that I think we're going to see much more targeted stuff come along at warp speed, if I can borrow that term. And they've done a lot of the work for us, and not specifically to prostate, but it can be adapted to the prostate issue. And so I think there's just going to be a lot of stuff coming along if it's not already there. And there's got to be a clinical trial for every one of those genetic abnormalities, even if it's just one that has a funny name. There's going to be somebody that has a drug for it that's going to be worth trying. But this is the tip of the iceberg, and I think you have a couple of avenues that you can still pursue.
All right, thank you very much.
Thank you, Doctor. Anybody else have any questions?
I have a follow-up question.
Okay, Lauren.
And I misspoke before. I said Mike Gleason was 8 or 9. It's a 4 + 5, and that's where the 9 comes in. So my question is, I had a low PSA. So as I come off the Lupron, what's going to be the trigger to indicate that maybe there should be further treatment or further investigation, since the PSA didn't indicate that I had cancer to begin with?
Yeah. Well, 4 + 5, again, the predominant is 4 and the minor pattern is 5. That's a very aggressive cancer. And in almost all of the high-grade cancers that respond, to initial Lupron therapy, then respond eventually to either the Provenge immunotherapy or to one of the combination therapies. In that instance, it's a lot of difference between a 4-5 than a 5-4. A 5-4 is just a different animal. But you know, the genetics of a 4-5 have to be some kind of mutation issue. That's just the way everything is headed. And the treatment for it is going to be very specific and targeted. If it's not already there, it's a clinical trial going somewhere. And a lot of that's being done in Southern California. UCI and UCLA especially is going crazy with this stuff. They're just, you know, they're leading the way in most of this research. And it's kind of nice to be at a time when you can see this development. Lupron is not as good as the new one. If you have to have more ADT, perhaps they'll give you the new one, which is, it gets rid of so much more androgen than Lupron does. So you have that to look forward to. And the androgen receptors like darolutamide that haven't been available is certainly something that you should consider. If you're going to use the new Lupron pill, then I think you probably don't need to consider abiraterone, but certainly the Provenge should fit into there somewhere. And it's been kind of interesting to see, we never used to use Provenge just didn't think it worked. And when it's an add-on, it's amazing how it adds 20-25% to the disease-free survival. Huge numbers, numbers like we haven't seen in clinical trials in a long time.
That's encouraging. Thank you.
It is.
Anybody else with any questions? Larry?
Yeah, I very quickly went and looked through all of my records here. And the genetic test that I had starting in 2017 towards the end of the year was Guardian 360, Liquid GPS, Invitae, Hereditary Genetic Prostate Cancer Panel, and Genomic, let's see, Tempus XF, I guess. Yes, those are the ones I've had. And nothing showed up.
Did any of them have a GPS score?
No. No.
No.
Well, wait a minute, Liquid GPS.
Yeah, the liquid part is the new one.
Yeah, Liquid GPS is the one that I had. And potentially effective drugs. PDL1, no evidence, no evidence. So ARV7, not detected. Obviously, me as a layman, I'm not so good at interpreting these things. So I'm hoping that the doctors that ordered this test for me, the oncologists, have looked at these things, and that when they tell me nothing, that I can believe them. But as you said, I'll give a whack on this one, and I'll ask about the other one that you just mentioned. So we'll see what happens. I'm optimistic.
Okay. Does anyone else have any questions? While I all got you here, I want to introduce Ira Caggett, who is our newly diagnosed group leader. And I know that a lot of you here are newly diagnosed and would like more information, like to get in touch with our newly diagnosed group leader. Ira, what is the best way for folks to get in touch with you?
I guess my email address is Shaloha to you, SHAALOHATOYOU SHA. Let me go. I forgot already. SHAALOHATOYOU@gmail. Drop me an email and give me your telephone number and I'll call you back. I'll call you.
Let's see if I can put that here. Give it to me slowly. I'm going to put it in the chat section so everybody
Okay.
can see it.
In fact, I could do it here.
You want to do that?
Yeah.
And
let
everybody
me
can
see if
see
I
that,
can
copy
type it.
that down for the newly diagnosed folks.
Let's see here.
There it is.
Thanks,
Just drop me a note, have your telephone number and I'll call you back.
Sounds good. Are there any other questions before we adjourn the meeting? Well, Doctor, I want to thank you for an outstanding presentation, and we certainly look forward to talking to you again very soon. Please keep us in mind for donations. Let's see, I see David Lehman. Is that a hand up, David? Oh, you're
No,
muted.
Neil, this is one of the things my grandson taught me to do. It was an applaud. It was hands clapping.
Oh, I thought you were raising your hand.
No.
So you're applauding.
Applause.
Yes.
Very nice. Basically, is there anything else before I adjourn the meeting? I thank you all. Prostate Forum will be working behind the scenes.
So Neil, just remind that next meeting is that
January, what is it? January, let me see here. Let me get my 2021 calendar out.
Give the date.
We're going to be, we're January 28th. It's the fourth Thursday, 7 p.m. to 8:30 p.m. Pacific Standard Time, in case you are in a different time zone.
We have the doctor from the Aussie from Lenzo, or
Dr. Nat Lenzo will be addressing us from Genesis Care on what basically will be theranostics. I'll be sending out several announcements via Constant Contact. If you're not already.
People ought to tell their friends. This is a real good opportunity for hearing one of the world's expert on this.
Experts on theranostics and a worldwide organization that is here in the US as well as Australia and the UK. This meeting was about a year in the making. In fact, more than that. We met with Genesis Care back in August and September of 2019 and booked them in just as soon as we knew how interesting their program was. So we urge you to join us, and we urge you to talk to other people about joining us as well.
This man was willing to fly here, but COVID would knock him out about 3 weeks. So we're fortunate for the Zoom format.
Yeah, Dr. Lenzo was the doctor that gave me my 3 cycles of lutetium in Sydney, Australia.
All right.
Oh, you know him, Larry.
Oh, yes, he knows me very well.
Okay.
He's a good speaker. He has lots to say.
Okay.
Yeah.
Don't miss the meeting, January 28th.
I shan't.
Okay.
Well, we look forward to, and again, if you need support services, you have our hotline number, you have our email. We are working behind the scenes. We are not going away in late November, December, or January. We will be here. So I wish you all a good night and good holidays if we don't talk before.
All right. Good night, to all.
Good night.
Be safe. Be safe.